Hey folks, Scott Weingart, and this is the EMCrit podcast. Today on the podcast, we're going to discuss pulmonary embolism. I mean, sicker pulmonary embolisms, not the ones you're sending home. And we're going to discuss a little bit about PERT teams. We're going to discuss a lot about fibrinolytics and catheter-directed therapies. So much good stuff. It's going to be a little complicated, but I think together we're going to get through it. Before that, two announcements. One is that the EMCrit airway bag called the RESA Scram is finally available. This was a multi-year project with Paul Swinton, who had developed the original Scram airway bag for pre-hospital use. When I saw that, I said, oh my God, this is just perfect, but some tweaks are needed if we're going to use it for the way I conceptualize airway. And it's here. And if you're interested in taking a look at that, go to emcrit.org/scram. You can see a video, you can see all sorts of information. And I really think you might like it if you are an EMCritter and like the way that we discuss airway on the show. And then the second announcement is we're doing a book club. Myself and Rob Orman of the Stimulus podcast are doing a joint book club on one of the most powerful books I've come across called Nonviolent Communication. And I think it's going to be a lot of fun to discuss this book. It's going to be November 14th. You can find all the information linked in the show notes for this episode or go to deeperstimulus.com, deeperstimulus.com. It is free, no charge, but only 40 slots. So if you're like, I'll sign up, but I don't really know if I'm going to go, please don't. We'll record it so you could get the passive viewing later. But we want people who sign up to actually show up and be ready to discuss the book. So check that out if you're interested. All right, let's get right into the show. Now, I tried to wrap my head around the best way to discuss all these issues because they're complicated. And what I came up with, and if you're willing to participate, is there's 2 pages I'd love you to either be looking at if you're listening in front of your computer or maybe print out, or if you're on a mobile phone, I put them in the show notes for the podcast audio itself. So if you scroll over to wherever that is on your podcatcher, you should be able to click these links and see them on your mobile phone. But it would really help. There's 2 images there. There's the pulmonary embolism pathway that I created based on all of the extent evidence I could come across. I think it's the best I could do, and I think I'd love to hear your thoughts on it. And then an image called the spectrum of systemic and catheter-directed fibrinolytics, which just is a different way of conceptualizing things than I've seen in most places. So if you're able to look at those 2 images, it'll really help. You don't need to. If you're in a car, don't worry. I don't want you to crash your car looking at these images. I'm going to walk you through them, but it would certainly be an easier thing for you to follow along if you're able to look at these as we go. So where we really stand is you have evidence of a pulmonary embolism, whether it's a CT or a high probability VQ scan. And there's certainly situations you're going to do all this treatment just based on suspicion. I'm not going to deal with that very much today. We've discussed that in other episodes of the podcast. So you have a patient has a PE. And your next step is to risk stratify. And, you want some inputs for that. You want to have the patient's vital signs over hopefully a little bit of a trend. You want to have their troponin and potentially a BNP as well. And you want a bedside echo. Now, if you can't get a bedside echo, well, then you use findings on the CT scan secondary to the pulmonary embolism, what the heart looks like on the CT. But an echo is really helpful, and I think in most places that is an obtainable thing, whether you're doing it yourself or you could just get someone to come to the bedside. And if the patient does not have any signs of RV strain, then in my mind, you could put them in a fairly low-risk category. Now, when you look at the guidelines, for instance, the ESC guidelines, the European Society of Cardiology guidelines, they would say you get into an intermediate category with either signs of RV dysfunction or elevated biomarkers. And I'm sure there is a level of troponin where I'd probably agree with them, but for the most part, just these scant, tiny little troponin elevations, I really don't think predispose you to having to do a lot of risk stratification. I mean, if they have those elevations, these would not be the patients potentially I would send home. These would not be the early discharge PE patients, but stratifying those patients into a category, what they said is you're in a low risk intermediate if you have RV strain or these biomarkers. And for me, RV strain is a very different beast than a tiny, tiny, tiny little high sensitivity troponin elevation. So I get what they're getting at, but I don't know if I really agree. So for me, it really gets you in the low risk category if you don't have any signs of RV dysfunction and no significant elevation of your biomarkers. And for those patients, you already know what to do. You put them on some form of anticoagulation. You either admit them to an internal medicine bed in the hospital, or you can consider discharging those patients. We're not going to deal with them any further than that. So let's discuss the intermediate risk category or the submassive category. And so for me, like I said, these are patients who are normotensive, or at least normotensive most of the time. We'll get to what that means in a second. They have a proximal clot, and they have signs of RV dysfunction, whether on CT scan or on your echo. And for those patients, my preference, and this has been a change from my prior practice, of a decade ago, is I want unfractionated heparin for their anticoagulation. What we're finding more and more is that the simultaneous use of anticoagulation and systemic thrombolysis, especially at the higher doses, probably predisposes you to a unnecessary amount of bleeding risk. So it's really nice to be able to turn off your anticoagulation at the time of giving systemic thrombolysis. And, so that implies unfractionated heparin. I mean, obviously not for patients with HIT or predisposure to HIT, but we're not talking about those patients. So we're going to use unfractionated heparin. Now, I will say here, and this is kind of controversial, that if I know I'm going to be giving a systemic thrombolysis to a patient, I might hold off on their heparin if I know what's going to happen, because it would be really great to just have a fresh, non-anticoagulated patient while I'm giving the thrombolysis, and then I could anticoagulate them afterwards. And that is controversial. Some guidelines recommend just give it no matter what. Jeff Klein used to recommend actually giving low molecular weight because he wanted to have it on board. But I think the results of current trials like PETHO would tell us maybe... Oh, my friends, I'm sorry. If you want to hear more, you have to become a member of EMCrit, and then you'll get the full episode, all of the diagrams, figures, etc. So please consider coming on over to emcrit.org/join for all of this goodness and all of the rest of the EMCrit offerings. Talk to you soon.